Thank you, and thanks for the invitation to the meeting. I know many of you came from a distance. For me, it was about a 40-minute drive from my house in Marin, so I'm at UCSF, and we'll talk about, we've covered coronary artery disease, valves, lipids, and now we're moving on to arrhythmias and our favorite arrhythmia, atrial fibrillation. I will say my main conflicts are that I did work with FARAPulse, which was the company that developed this technology used in Advent, subsequently bought by Boston Scientific. I was on the steering committee for the trial, but I didn't accept any payments for that. So has anyone, I'm just curious, not heard of pulsed field ablation, since this is maybe more of a general cardiology? How many people have heard of pulsed field ablation? There we go, okay, I thought maybe some people are sleeping. That's okay. So just as a background, pulsed field ablation, again, is this new energy source everyone's excited about for ablation. It's a non-thermal way of ablating tissue. So it's been used for a while for oncology. If you look at the, there's a pointer here, but if you look at the bottom, it's basically applying an electric field, a high voltage electric field to tissue. If you apply in a certain field strength, you get reversible electroporation, which means pores form in the cell membrane. You can transfect drugs into the cell and then they heal. But at a higher voltage, shown here in this yellowish color, you form many large pores, the cell contents spill out and the cells die. So it's a non-thermal way of ablating tissue. If you crank the voltage up enough, though, you will have thermal effects. The advantage of this are, one, it's fast, so without getting too much into the waveforms, the pulse is basically 100 microseconds. Usually it's applied as a train of pulses, so maybe over 2 seconds. So as opposed to what we do with catheter ablation with RF, where maybe 20 seconds for each lesion, here it's about 2 seconds. So one advantage is speed. The other is where we just got lucky with this energy source, that it seems that myocardial cells are much more sensitive than other cells. So shown here at the bottom is the threshold for injury from myocardium, and smooth muscle has about 4 times as high a threshold for injury. Why do we care about smooth muscle? Because obviously the esophagus behind the left atrium is made out of smooth muscle, so it seems much harder to have esophageal injury, and then nerve is even higher, and the other thing we worry about with AFib ablation is the phrenic nerve. So important to realize this is relative tissue selectivity. Doesn't mean you can't injure it if you hammer it, but people have ablated in preclinical models directly on the esophagus or phrenic nerve and not shown at least permanent injury, so that's a potential advantage. So that led to this Advent study, again sponsored initially by FARAPulse and then Boston Scientific. This was a pivotal study, so a multicenter, prospective, non-inferiority RCT of pulsed field compared to thermal ablation. Probably the only study that will be done comparing it to thermal ablation, because now that it's been approved, other studies will just be single-arm studies. The objective was to compare both effectiveness and safety of PFA to standard of care thermal ablation using current technologies, so either irrigated force sensing RF ablation or cryoballoon. All these patients were first-time de novo paroxysmal AF, so there are subsequent studies now looking at persistent, but this is paroxysmals. It was a 1-to-1 randomization to PFA or thermal ablation. And importantly, it wasn't by operator, but each center had to pick, are they primarily a cryo center or an RF center? And they could either then use RF or cryo as the control arm. And the centers were assigned, so there would be roughly a 50-50 amount of RF and cryo in the control arm. Patients were followed for 12 months after ablation. The efficacy was based on 72-hour Holters at 6 and 12 months. And patients were also sent a monitor. There was a 3-month blanking period. And then they sent transmissions every week, whether or not they had symptoms, and also with any additional symptoms. So as you can see, they were just randomized to pulsed field or thermal ablation. The primary endpoint was acute and chronic success, which was freedom from not just AFib, but flutter or any atrial tachycardia, freedom from repeat ablation. So you'll notice some studies have repeat ablations being allowed, no repeat ablation, no cardioversion. And I think this is important, that a lot of times you'll see the outcome and it's kind of like with previously tolerated antiarrhythmic drugs, right? It's sort of watered down. We kind of pushed Boston to say, this is freedom from AF without drugs. We really want a pure endpoint. The ultimate testing was non-inferiority because we thought we'd need too many patients to achieve superiority. That was a secondary endpoint. And then safety was any SAEs, serious adverse events at 7 days, or any pulmonary vein stenosis or AE fistula out to 12 months. The secondary superiority endpoint was looking at pulmonary vein diameter. So everyone got a baseline and 3-month CT or MRI and looking at any pulmonary vein cross-sectional narrowing. So it was a modified intention to treat, meaning you had to have some energy applied to be counted in the randomization. So for example, the TEE showed a left atrial appendage thrombus and you weren't ablated, you were dropped out. So in the end, there were 607 patients randomized, 305 to pulse field, 302 to thermal ablation, and you can see I added in the split about 162 RF, 135 cryo, and about 290 in each arm completed the 12-month assessment. This is just an example from a patient, just to see. The left is a fluoro image. So this is a basket catheter. It's a pentaspline catheter. It has 7 splines, and the PFA is applied amongst all those splines simultaneously. And generally, you're doing about 8 applications per pulmonary vein. The right is a voltage map. Again, it's just showing red is dead, so after ablation, the pulmonary veins are isolated. Purple is healthy tissue. And just to show how quick this is, I promise I'm not going to show any other electrograms, but these yellow is the electrograms on this basket catheter, and you'll see 1 application of PFA over about 2 seconds. And you can see pretty quickly it wipes out all those electrograms. So in terms of the patient population, pretty typical of what we see for paroxysmal AFib, mean age of 62, mean CHA2DS2-VASc about 1.7, left atrial diameter about 3.9 centimeters. Patients had to fail either an antiarrhythmic or could have just tried class 2 or 4, which are beta blockers or calcium channel blockers. So importantly, about 60% of patients had broken through antiarrhythmic drugs, but about 40% had just tried a beta blocker, calcium channel blocker, and went straight to ablation. That was allowed. This is the ultimate primary effectiveness of freedom from all those things I mentioned, any atrial arrhythmia off drugs, didn't meet the equivalence endpoints of 71% for thermal ablation and 73% for PFA. Now, some people looked at this and were kind of displeased, right? PFA had all this hype, it's going to be the latest and greatest, yet even after all this, it's really equivalent to thermal ablation. Why should we try something new? I think some important points. One is that, we've gotten pretty good at thermal ablation over the years with contact force, high power, short duration ablation. This is just showing some of the other pivotal randomized trials that have been done. So cryoballoon initially maybe looks similar, 70% freedom, but if you look at the data, about 20% had a redo ablation. So with one ablation, success rates more in the 50s. I was involved in the laser balloon compared to RF, again, about 62% freedom from AF. Fire and ice was a comparison of RF and cryoablation, about 64%. And then Pulsed AF is a different company's PFA catheter. Again, 66% freedom from AF, but that included people on previously intolerated drugs. So if you look at the 73%, you'd say, hey, that's pretty good. And this, after optimizing RF over 20 years or so, this first attempt at a new technology was equivalent. What about safety? It was actually pretty good if you look at serious adverse events in both arms. So in the PFA group, about 2% serious adverse events. In the thermal group, it was about 1.5% adverse events, pretty low. There were 2 patients in the thermal group that had phrenic nerve paralysis, both from cryoballoon. Those weren't considered serious events just because the definition was prolonging or requiring hospitalization. If you move those over, though, to the thermal group, you end up with 6 and 6, so pretty much 2% adverse outcome in both groups. Importantly, this pulmonary vein stenosis, AE fistula, 0 in both groups. Again, a pretty rare complication, so we didn't see that with thermal or PFA. You still get mechanical complications, and again, this is a new technology, larger sheath. It's a 13 French inner, 17 French outer sheath. So there were some tamponades in the PFA group. And importantly, there was one death from a mechanical complication. Someone who had tamponade, needed cardiac surgery, ultimately didn't recover. This hasn't recurred in larger groups of patients, but important that mechanical complications can still occur. PFA was faster. Again, we've gotten pretty good at RF ablation. So the procedure time, LA dwell time, and ablation time were significantly shorter for PFA. The total time, again, for a new technology was 105 minutes. The study mandated a 20-minute waiting period, which didn't really result in any pulmonary vein reconnection. So if you subtract that off, it's about 85 minutes. For a new technology, most people in clinical practice are doing this in about 60 minutes. Again, some people are pretty good clinically with RF, but I still remember the days where we spent like 10, 12 hours. So the fact that skin to skin, a whole procedure for an AF ablation can be 60 minutes, I think is an advance, not because time really matters, but it's less general anesthesia time for the patient, less left atrial dwell time, probably lower risk overall. The fluoro's time was a bit longer because this catheter wasn't integrated with any mapping system, so we're doing it just by fluoro alone, potential limitation, but now future versions will have mapping systems. If you mentioned, we talked about pulmonary vein stenosis. There were no true stenoses in either group, but if you look at the bottom, I think this happens, not infrequently that we don't appreciate because we don't do follow-up CT scans in everyone, where in the left, you see the full pulmonary vein diameter, and the right, you see some minor narrowing. So with thermal ablation, there was about a 12% narrowing, but none with PFA. And I do have occasional, out in Napa, we have like triathletes or San Francisco bikers. I do have an occasional patient in my practice that says they don't seem to be able to get quite to their level of endurance that they could prior to ablation, and maybe this is something that'll help with that. So from Advent, the conclusions were that efficacy and safety was non-inferior to thermal ablation. With all ablation technologies, safety and success were better than anticipated. I just thought I'd add one other slide from a larger group of patients, because again, what can you conclude from 500 patients when some of these complications, like AE fistula, are pretty rare? So this is Manifest 17K, 17,000 patients since the catheter has been approved in Europe. And just to point out again, over several years, no esophageal fistulas, no PV stenosis, no phrenic paralysis. There are some other minor complications that are new. Hemolysis can occur, coronary spasm if you're ablating near a coronary, but also pretty infrequent. So to summarize, PFA has equivalent freedom from atrial arrhythmias compared to thermal ablation. Procedure time, LA dwell time are shorter. No reported LA fistula, PV stenosis, or persistent phrenic injury, but other mechanical complications can still occur, and some new rare complications such as coronary spasm or hemolysis. The companies are charging a lot for these catheters, about 50% higher than thermal ablation, while reimbursement's the same. So hopefully this will come down, but it's definitely something to consider. But I think it will expand the population who maybe are thinking about ablation because of a shorter, safer procedure. And this is where I drove from in Marin. So thank you for your attention.